Welcome to Higher Change. I'm Dr. Thomas Luttrell, and today we're going to talk about sex, specifically sexual behavior, sexual identity, and sexual diversity. Sexuality is an important part of who we are as human beings. Both biology and psychology play a role in our sexuality. Sex can be great, but it can also have destructive consequences. The difference can have implications for psychology. So we're going to talk about a lot of things in this lesson. We're going to talk about taking a sexual history, the models of sexual response cycle. We're going to talk about the basic sexual disorders, common reasons for why people have a low sexual desire, the role of emotional intimacy in sex. We'll talk about what is meant by the politics of sexual desire. We'll talk about basic sexual fantasies, and we'll talk about sexual orientation and the complex etiology behind it, as well as how to protect your sexual health and what is sexual consent and why it's important. So let's talk about human sexual behavior. First, let me ask you this question. What is the largest sex organ in the human body? Think about it. What's the largest sex organ in the human body? Well, it's the brain. The brain transmits and controls sexual impulses. It also gives meaning to sexual activity, which can then enhance or detract from sexual desire. So let's talk about the history of studying sex, or sexology as people call it. Well, sexuality was once a taboo topic to talk about. Women were diagnosed with hysteria, which, as you may recall, is related to a woman's uterus. Doctors would treat women with hysteria through sexual means. Now, there is a movie on the subject called Hysteria, and set in the Victorian era in the 1880s. The movie Hysteria shows how the medical treatment of female hysteria led to the invention of the vibrator. Now, Freud believed that sexual repression was a cause for a lot of problems and introduced psychoanalysis, a talk therapy. So it's different from what doctors would do before. So he preferred talk therapy. And yet there's still a lot we did not know about human sexuality. And even talk therapy had its problems. Carl Jung fell in love with a woman who was diagnosed with hysteria that he was treating using psychoanalysis. And that's the subject of the movie Dangerous Method. The movie illustrates the danger that comes with getting into the personal lives of patients. And what was the dangerous method? It would be psychoanalysis. Just talking about personal details would create an intimate relationship between the therapist and the client. And so that came with its potential dangers, and that's why they had to establish boundaries. So there are 3 landmark studies about sexuality that helped advance the professional study of human sexuality. First, in 1948 was a study by Alfred Kinsey that looked at sexual diversity. Then Masters and Johnson published their research on the human sexual response cycle in 1957. And then the Janus report on sexual behavior came out later in 1993. And there's a lot of other research studies, but these are the most significant that you would want to know about. In 1948, Alfred Charles Kinsey published the first of the Kinsey reports. This was one of the first scientific investigations into human sexual behavior. The movie Kinsey, in 2004, describes the life of Alfred Kinsey, a pioneer in the area of sexology. Now, Alfred Kinsey would oftentimes ask personal questions to understand where people were coming from sexually. And this is called taking a sexual history. Sex therapists and other professionals in this area still do this. They'll ask questions about your first exposure to sex, your first sexual experiences, your dating history, and the number of sex partners you've had, and that sort of thing. And this is just to help them understand your overall exposure and relationship with sexuality in your life. And so this is a useful tool that people still use. Now, the television series Masters of Sex depicts the life and times of William Masters and Virginia Johnson. And this is a picture of them in 1970. And they were the ones who first introduced the idea of the sexual response cycle. So we'll talk about that next. So in 1957, William Masters and Virginia Johnson conducted the first direct observational study on the physical aspects of the human sexual response. So William Masters, who was a gynecologist, and Virginia Johnson proposed a physiology model with 4 phases of human sexual response. The first is arousal or excitement, and this involves the physical arousal of sex organs. The second phase is the plateau, and this is when there's physical changes that lead to orgasm. And then there's the third phase, according to them, was orgasm, which is a series of rhythmic contractions of the muscles of the vaginal walls or the penis, which is also the shortest phase of the sexual response. And then the last phase, according to them, was resolution, when the body returns to an unaroused state. Now, they could theoretically go back to having another orgasm, but for men, it required a period of time, which is what they call the refractory period. So let's look at this. This is the male response, and so they have slightly different response cycles for men and women. This diagram illustrates for men. And the refractory period, like I said, is a time period in males just after orgasm in which the male cannot become aroused or achieve erection again. So this time period may vary depending on the age and stamina of the male. Now, the female sexual response cycle looks different. So as you can see, for Masters and Johnson, they believe that women follow a similar response cycle in the beginning, in the sense that they go through excitement and plateau, and yet their orgasms can occur more often. They can occur sooner, but they can also they can have more repeated orgasms and before they go to resolution, and that's because women don't have the same kind of refractory period that men do. Now, unfortunately, the linear model tends to be male-centered and reinforces the idea that orgasm and penetration were necessary for a woman to have pleasure. So there has been a lot of criticisms of the Masters and Johnson model. But it was the beginning. Now later, Helen Singer Kaplan added an additional stage at the beginning related to desire. She argued that optimal sexual arousal involves not only physical stimulation, but also mental or psychological stimulation, which depends on our unconscious needs and desires. So Helen Singer Kaplan was paying much more attention to how women were experiencing their sexual response cycle. Now, Masters and Johnson, they started with men. Their first publication was on men, and then they looked at women in their next publication. So it may be biased because they started from a male framework, whereas Helen Singer Kaplan was much more interested in the woman's response. So she added the psychological dimension to the physiological dimension. As you can see, the physiological dimension, according to her, has the excitement and orgasm phase, but prior to the arousal and excitement, she would add sexual desire. And so she believed that there's a psychological component that is necessary prior to the physiological arousal. So this is what she added. So this is her revised model. She adds sexual desire, which is the psychological dimension that precedes the physiological dimensions of sexual arousal and orgasm. Now, if we compare Masters and Johnson's model with Helen Singer Kaplan's model, the main difference is that she adds the sexual desire component at the beginning. So we can actually create a 5-step revised sexual response cycle, and it starts with sexual desire. Sexual desire is when a person is turned on sexually, and this is on a psychological level. So this may involve seduction, it may involve fantasy, or attraction, and this is turning the person on and getting them ready for the physiological arousal. So the second stage is physiological arousal or excitement, and this is when blood flows to the genitals and creates an engorgement of either the vagina and the clitoris or the penis. Then after a while, there's a plateau, and that's when things start to level off right before orgasm. Orgasm is when there is a rhythmic contraction of muscles in the vagina or the penis. And then after the orgasm, there's a resolution. Now, resolution may look different for men and women. Women might have a very brief resolution before she goes, or a drop right before she goes back into another orgasm. She can have another orgasm and then a resolution. There are other models of sexual response that we also want to look at. David Schnarch introduced his quantum model in 1991 in his book, Constructing the Sexual Crucible. In his approach, he introduced this idea that there are several thresholds that one would need to cross in order to have a complete sexual response. So the first threshold is the arousal threshold. So this says that that sexual desire creates the foundation necessary for arousal. And so at a psychological level, people need to want their partner, and they need to have a sense of desire and attraction for their partner. And then after they have enough desire, they will cross that arousal threshold when there's a physiological response in the genitals. And then after a while, they hit an orgasmic threshold. So the orgasmic threshold is a threshold which is necessary to cross for a person to experience an orgasm. And once they cross that threshold, it's like the point of no return. Once they start to have an orgasm, they can't stop. And then after that, the body returns to its normal state. So that's the basic idea, is that there's two thresholds. But the main contribution of this approach is, like Helen Singer Kaplan's approach, it really stresses the importance of desire as a foundation for sexual response. David Reed also introduced his idea of the erotic stimulus pathway in 1998. He focused more on the psychosocial aspects of the human sexual response. So he was getting away from the more biological-driven approach and wanted to understand the sexual response from a purely psychosocial perspective. This is very important for people who may not have the typical biological response, maybe due to injury or some other reason. And so this has been very helpful for people. So according to David Reed, there's 4 phases of the erotic stimulus pathway. First, there's seduction. This includes those things that we do to turn each other on. For example, someone might dress up in lingerie, or they might wear some perfume, or they might talk dirty to their partner to turn their partner on. And so this is seduction. Then there's sensation. This is when we're open to sexual stimulation from all our senses. This may involve imagination or fantasy that is arousing. And then there's surrender. And again, this is more about the psychological aspect. Orgasm requires surrendering and giving up control. So we have to stop spectating or worrying about how we look. Otherwise, if we are constantly worrying about how we look, it'll be hard to actually have an orgasm. And people experience what they call performance anxiety. It really inhibits somebody from crossing that threshold. And lastly, there's reflection. When we decide if that was a positive or negative experience, this would lead to future changes. Maybe they might want to do it again or not do it again. Now, in 1997, Beverly Whipple and Karen Brash McGreer created the circular model that was specific to women. The linear model has been considered too male-centric and is too focused on orgasm. So they believed that if a sexual experience resulted in pleasure and satisfaction for the woman, she would want more. And that's not necessarily tied to orgasm. It just means if they have pleasure and they're satisfied, then they'll want to do more of that. Now, Beverly Whipple was the one who popularized the concept of the Grafenberg spot, or the G spot, in her book. So she was very much interested in women's sexuality. Prior to her research and her publications, people didn't really understand a lot about women's sexuality, as the focus had tended to be more on male sexuality. Now, Rosemary Besson also expanded on the circular female model, and her model looks like this. It's really based on intimacy. So she starts with emotional intimacy. And emotional intimacy is what motivates the sexually neutral woman to be responsive to sexual stimuli. So without intimacy, then sexual stimuli can actually just be a turn-off. So intimacy is what's really important here. Then sexual stimuli leads to sexual arousal. So that's the psychological component leading to the physiological response. But then there's arousal and sexual desire. So there's a physiological response, but there's also psychological desire occurring at the same time. And then after that, there's emotional and physical satisfaction. So if they experience satisfaction, and that is not necessarily tied to orgasm, but it could be, but if they have satisfaction on emotional and physical level, then they're going to want to have more of the same. But the emphasis here really is on intimacy. It's how sexuality creates intimacy and draws people together. So in this approach, female desire is more responsive than spontaneous. When she's turned on and stimulated by her partner, desire emerges and motivates her to continue. Now, there may be some spontaneous sexual desire, but it's not as necessary. But women can experience spontaneous sexual desire at any point in the cycle, and that's unique to women as well. Let's talk about sexual disorders next. Sexual disorders is classified based on the response cycle. So sexual dysfunction is a problem with sexual functioning or the actual physical workings of the sex act and can be caused by a number of factors. So we classify sexual disorders based on, as I said, based on the response cycle. So there's typically dysfunctions in sexual interest, then there's dysfunctions in sexual arousal, and then there's dysfunctions in sexual response. Now, sexual disorders of sexual interest may be that they have no sexual desire, and that would be one. Disorders with regard to sexual arousal may include the inability to have an erection or the inability to have penetration for a woman. And then sexual response has to do with the inability to have an orgasm. And so these are how sexual disorders are classified. Now, 40 to 50% of women report having some kind of sexual dysfunction. What are most common among women include hypoactive or low sexual desire. So this is called the hypoactive sexual desire disorder. Then there's female sexual arousal disorder. And then there's female sexual dysfunction. Among men, there's 20 to 31% of men who have some sexual dysfunction. And the most common among men are premature ejaculation and erectile dysfunction, or ED. So the inability to have an erection. So if we look at common complaints among men and women, you can see how they differ. So women are more likely to report a lack of interest in sexuality, although it can be problematic for them. Whereas men tend to complain about climaxing too soon or not being able to hold their erection. On the other hand, women are more likely to complain about having difficulty lubricating because that's unique to them. So these are some common sexual dysfunctions between men and women. Now, there are biopsychosocial factors involved. That means there are organic or biological, as well as social, cultural, and psychological factors that can contribute to sexual dysfunctions. Therefore, both medical and psychological treatments are typically employed. Physical sexual response cannot be separated from the psychosocial factors, including cognitions, relationship issues, and the context of sex. Now, I like David Schnarch's approach because he helps us to look at how these disorders are classified based on the response cycle. So in the first approach, according to his quantum model, as you recall, it has inability to cross certain thresholds. So one dysfunction may be related to the inability to cross that arousal threshold. So this is when somebody has no erection and no lubrication simply because they have no desire. Now somebody may cross the arousal threshold, but then they're not able to go any farther. So this is because they may have a lost erection or a lost lubrication, or they just have difficulty having an orgasm. Then there are some people who are able to cross the orgasmic threshold, but it may come too quickly. And so this is premature ejaculation. And then there are those who are almost able to cross the orgasmic threshold but are not quite able to. And so this might be retarded ejaculation or female orgasmic dysfunction, meaning they're not able to have an orgasm. They're just almost there, but they just can't cross that threshold. So this is one way of visually depicting these kinds of sexual dysfunctions. Now, one of the common complaints, as we mentioned, is low sexual desire. This could be due to several reasons. But this is when people say things like, I've lost my sexual attraction and my desire for my partner. So what would cause this loss of desire? Well, there could be a number of things. It could be biological, but it could also be due to the relationship. Individual causes may include things like religion, personality issues, there may be some gender identity issues, some fears, phobias that may have arisen. The person may be depressed. Depression can actually cause a loss of sexual desire on a psychological as well as a biological level. So that leads us to the biological reasons. There may be hormonal problems, or there may be issues due to medications. So some medications can also cause a loss of sexual desire. And there could also be concerns about aging, or there could also be insecurities that people may have about their looks or whatever there may be. On the other hand, there could also be some relationship problems. For example, maybe somebody just stopped being attracted to their partner for whatever reason. That could be due to their partner's changes in their physical appearance, or maybe because of how the other person's treating them. There could be a loss of trust. Maybe someone doesn't want to open up to that person because they don't trust that person. Maybe they think the other person is being unfaithful. And so that might be a good reason not to have sexual desire for that person. There could be conflict in the relationship. And this is oftentimes forgotten when people talk about the loss of sexual desire. Maybe they don't want their partner because there's conflicts and arguments going on. There may also, and due to those kinds of things, there may be a fear of being intimate or vulnerable with that person. Other reasons may include power imbalances or the lack of equality. For example, if somebody's been doing work around the house and the husband or the other person's not doing any work, then if he's demanding sex after she's been doing all the work, she just may not want to. There's a saying that says sex starts in the kitchen. And, basically it speaks to this idea that equality starting in the kitchen is very important for sexuality. Now, there may be inability to turn love into desire. Maybe they love each other, but they're not able to translate that into desire for whatever reason. There may also be a spiral of negative perceptions and emotions going on in the relationship, or difficulties with communication and intimacy. So all these can cause a loss of sexual desire. Other issues can also be due to inhibitions. Maybe someone doesn't want to open up sexually because they have some taboos due to religious or cultural beliefs. Or maybe they have some influence from their family of origin. Maybe there's some abuse or problematic beliefs that they've adopted from their family. There may be some trauma or shame that they've experienced that would make it harder for them to open up. And lastly, there could be a loss of self-esteem or a poor self-concept that may make it hard to open up. But the main point here I want you to take away is that the brain influences how we respond sexually. That, as we said before, the brain is the largest sex organ. It decides whether we want to respond positively on a sexual level or if we are not interested in sex with somebody. So that leads to the important role that emotional intimacy plays in our sexuality. 60 to 80% of women and 25% of men fake an orgasm. Why is that? Well, maybe because they're insecure about their own sexual functioning. Anxiety may make it difficult. Maybe they've had failed past relationships and they fake it in order to feel secure or avoid feeling insecure about their sexuality. Or maybe they just want to get it over with quickly. And also there's this idea of altruistic deceit. Some people don't want to hurt their partner and they just want to preserve the relationship. But in general, great sex is not about having intense orgasms, but rather it's about increasing the capacity for intimacy and eroticism within the context of a committed relationship. This is what David Schnarch says. That's really about, it's not about having an orgasm. It's about the capacity for intimacy and eroticism. It is a combination of stimulation plus feelings and thoughts that actually help a person reach their arousal or orgasm threshold, according to Schnarch. If you recall Schnarch's idea that there is an arousal or orgasm threshold, in order to cross those thresholds, you need positive feelings and stimulation. But even with the best stimulation, if the feelings and thoughts are not there, a person will not reach their sexual potential. Now, according to Schnarch, he really believed that people have a great capacity to reach their orgasmic potential or their sexual potential, and it may be involving orgasms or not, but he also believed that people have the capacity to really achieve a lot sexually and even have multiple orgasms. But it's really due to, you really have to have that emotional intimacy as a foundation. And he believed that sexual potential requires more than just physical arousal, but also the ability to create intimacy and engage in emotional connection. So Schnarch believed that sexual potential can actually increase with age as people become more emotionally mature. This actually goes against this idea that young people have the hottest sex. He believed that people have hotter sex when they have a greater emotional intimacy. He believed that great sex requires each partner to create eroticism, desire, passion, love, and emotional connection. Now, he would say people have boring, monotonous sex because intense sex and intimacy and change itself are far more threatening and fearful than they can imagine and require more adult autonomy and ego strength than they can muster. Intimate sex is, for most people, a terrifying and utterly mysterious business. And so that's why Schnarch talks about the importance of self-differentiation. You can't worry about what other people think, or you're going to be caught up in performance anxiety. So in order to really achieve your sexual potential, you have to have courage. So he would say through sex we can encounter, though usually we repress it, the fear of not being loved and the terror of losing what we love, the dread of exposing everything within us that is vulnerable and helpless, inadequate and impoverished, or ugly and hateful. To see inside each other during sex requires courage, integrity, and maturity to face oneself, and, even more frightening, convey that self, all that one is capable of feeling and expressing, to the partner. He would say that sex is like a window to the soul, essentially, or to look into the eyes of the partner is like a window to the soul. And sex involves oftentimes up close contact like that. And so, to have an up close contact with somebody really requires courage to be able to open up oneself. So eroticism is not just about more communication, though. That's one of the problems people oftentimes think. They think talking about things will actually enhance their sexuality. Well, talking is important, but it's not just communication. In fact, sometimes too much communication can also take the excitement out of it. But they would say too much sameness is going to result in boredom. It's really about being true to ourselves and being authentic. Being able to maintain some differences even while we are connected. So that's why Schnarch talked about the importance of self-differentiation. It's not just about communicating, it's about holding on to ourselves. Holding on to ourselves while we're connected. So what is sexual satisfaction, though? Is it just based on orgasm? Is that all it is? Are we just looking at this from a biological approach? Well, actually, it's really, as we said, has a lot to do with intimacy. But intimacy depends a lot on equality. As we said in our previous chapter, John Gottman talked about how intimacy depends on equality. Equality in a relationship is also important for sexual satisfaction. So equal couples tend to have higher sexual desire for both partners, and that is important for sexual satisfaction for both partners. So otherwise, you just end up with one partner who's sexually satisfied and the other one's not. Unfortunately, sex can be a source of conflict for couples. That's because underneath sex, there are power dynamics that go on. David Schnarch talks about the politics of sex. He would say that on one hand, people need to be wanted or desired, but on the other hand, sometimes we don't want or reciprocate because the other partner may want something from us, but maybe we don't want to give it to them. Sometimes if power is imbalanced in a relationship, as we said before, in the face of inequality, that makes vulnerability difficult. It's hard to open up somebody when they have more power over you. So if the power is imbalanced in a relationship, then vulnerability is going to be difficult. And that means vulnerability with regards to sexuality as well. So he would say sometimes the one with the least interest in sex has power over it. For example, as I said, if somebody feels like they're not being respected or they're doing a lot of the work around the house, they may not want to open up sexually. And that, somebody may think that they're using that as leverage. Well, it's their body, and so they don't want to. If they don't want to have sex, they don't want to have sex. And so, it may be a form of power, but it is what it is. Unfortunately, differences in desire result from these power struggles. High desire partners oftentimes define the low desire partner as the problem. So sometimes these couples will come to sex therapy or counseling because he thinks the woman's being frigid or he thinks she's being resistant. When the reality is that maybe she's just upset because he's not respecting her or he's not treating her as an equal partner. So unfortunately, the more one partner tries to demand sex from the other, the less likely the other partner will want it. So how do you break out of that? That really results in emotional gridlock. It really requires that somebody's willing to break the cycle. David Schnarch says, in some of these couples, they'll say to themselves, I'll tell you about myself, but only if you then tell me about yourself. If you don't, I won't either. But I want you to, so I want to, so you have to. I'll go first, and then you'll be obligated to disclose. It's only fair. And then if I go first, you have to make me feel secure. I need to be able to trust you. Well, you can't force somebody to disclose. Otherwise, you end up being an emotional deadlock, because if both partners are waiting for the other person to go first, then nobody's going to want to go first. But I've seen many couples where they don't want to open up sexually or express their love for the other partner until the other person does. Well, then you're never going to go anywhere. That's what we call emotional deadlock. So people have to ask themselves, are they going to continue to fake it or pressure the other person? Or are they going to risk real vulnerability and actually have intimacy in their relationship? He describes the difference between self-validated intimacy versus other validated intimacy. It only takes one person to decide that they're going to want to open up sexually to the other person. You don't have to wait for the other person to go first. You can decide to go first too. But it really takes courage, as I said. And so that's why our spirituality can actually be very important for our sexuality. When one person really believes that they're valued to God, or that they don't have to be ashamed of their bodies or of their past or themselves, then they can have courage to open up sexually and not have to worry about what the other person thinks. Unfortunately, religious guilt can sometimes impede sexual satisfaction. Multiple studies show that religious women, however, experience greater sexual satisfaction than non-religious women. And there may be many reasons for this. We oftentimes think that religion is bad, and it can be, but it doesn't necessarily have to be. Spirituality can be helpful. So, for example, people who save sex for marriage oftentimes don't have as much baggage when they have sex with their partner. They don't have any comparisons. Marital commitment enhances sexual fulfillment because it creates that trust and safety, and so they can feel free to open up sexually to each other. Also, the lack of sexual anxiety about disease or rejection also increases their sexual satisfaction. And spiritual commitments lead to a holistic sexual fulfillment beyond technique. And lastly, they experience less guilt and shame, which can be very important for them to be able to open up sexually. Our spirituality is very important for our sexuality. It helps us to be vulnerable. It helps us to accept our partners, to be able to forgive. And we can re-idealize our partner and to look at the good in them. Sometimes we can be so critical of our partners rather than seeing our partners as human beings. It helps us to be able to give even when we don't necessarily receive, because we want to, not because we have to. So we are able to be gracious. And sometimes grace is what's really missing in couples relationships. And you really need grace to have great sex. Now, Masters and Johnson also introduced a technique that can help people to reestablish their sexuality. And this is good for people who have had breakdowns in their sex lives, or they've had some stalling in their relationship. And so Sensate Focus is the method they developed to help them reconnect sexually. So this is a step-by-step process that helps people to start with basic non-sexual touch that gradually increases to the sex act, but over a period of time. And basically it encourages them to really slow down and really enjoy the sensations and their sensuality, and just to reconnect on that level. Because sometimes people are so focused on the orgasm or the penetration that they forget to really just appreciate each other and really enjoy the pleasure that they get out of each other. Now, I want to also talk about the diversity of sexual behavior next. We talked a lot about the sexual response cycle, but there's also many different ways people engage in sex. In 1948, Alfred Kinsey published his findings from a large survey of adult sexual behavior in the United States. They are collectively called the Kinsey Reports, and they contained highly controversial findings about sexuality. He also created the Kinsey Scale, which looked at how people they can be on a continuum between heterosexual orientation and a homosexual orientation. So he's the one that really got us away from this bifurcation, or this dichotomy between heterosexuality and homosexuality. And he really helped us to see that there's varying bisexual responses in human behavior. Now, most people might identify as being on either of these extremes, but there are some people who will fall in the middle. And he would measure this sexual orientation based on people's attraction, their behavior, the fantasies that they have, their emotional preferences, their social preferences, the lifestyle preferences, and how they identify themselves. In 1993, the next large-scale study of human sexual behavior was published by Samuel Janus and Cynthia Janus, and this is called the Janus Report on Sexual Behavior. They looked at more types of sexual behaviors and related factors than Alfred Kinsey did. In addition, there is the National Survey of Sexual Health and Behavior from the Indiana University that offers an ongoing look at sexual activity in the United States. Now, I want to talk about sexual fantasies. According to Professor Glenn Wilson of Gresham College, people tend to have 4 different kinds of sexual fantasies. There is the intimate fantasy, and this involves kissing passionately, intercourse with a loved partner, oral sex, making love in a romantic outdoor setting. And so this is one category. It's a very common, probably one of the more popular categories of sexual fantasies that people have. But it's not the only sexual fantasy. So let's talk about the other fantasies that people have. Another category of fantasy is the exploratory category. This involves non-monogamous behavior. So it may involve swinging, being promiscuous, or looking for novelty. And many people have this kind of sexual fantasy. And in my understanding, I could be wrong, but this seems to be what a lot of men tend to gravitate toward. But it's not exclusively. On the other hand, there's another category, is the sadomasochistic category. This involves someone tying somebody up, or being whipped or spanked, or being forced to do something. And in my understanding, this is the category that women seem to be drawn more toward than men, although there are some men who also experience this as well. And the last category is the impersonal category. And this involves fantasies about sex with strangers, watching others, being turned on by items of clothing or other fetishes, and pornography. So basically it's impersonal, not personal. So this may involve some type of avoidance or emotional avoidance. Now, in the sadomasochistic category is basically what we call BDSM. This is popularized by the movie 50 Shades of Grey. And BDSM is a variety of erotic practices or role playing involving bondage, discipline, dominance, submission, sadism, and masochism. And that's basically what BDSM stands for short. BDSM involves role playing a fantasy involving an exchange of power. However, it does not mean people want to be abused or assaulted in reality. It's just a fantasy, and people need to understand that. And consistent with that, consent is carefully negotiated. So, it's important to understand that consent is very important in healthy sexual behavior. And so even for people who are engaged in this fantasy, they will negotiate consent, and they may even use a safe word. So, for example, in some cases, they may want to pretend that they don't have any power, that they're being dominated, but the reality is that they do have power. They still have power. It's just a fantasy. So they may use a safe word that helps them get out of that situation, or communicates to the partner when they want to change something. Now, why do people do these things? Well, there's a theory that sexuality serves as a repair or defense against some of our past hurts. And so this comes from some research that I found. One of the articles I came across is published in Psychology Today and talks about shame and sexual desires. So there's a relationship between our attachment styles and our sexual fantasies. We've talked about attachment styles in the past. So, our past hurts and wounds can actually inform our sexual fantasies. And sexual fantasies often involve exchanging power. Well, why is that? Well, if you've been hurt, then you may have a fantasy that involves reenacting that hurt and fixing that hurt on an unconscious level. So ask yourself, what do these fantasies, you may have one of these types of fantasies. So you may want to ask yourself, which of these categories do you associate with? And then what does it say about the shame that you have in your life? Or what are some of the fears you have? Or what do you want to be in control of? Now, there's some conflicting research about the subject, but in my experience working with people, I've come to understand that, sometimes we're trying to re-engage in a scenario and gain control over that scenario so we can feel better. So, for example, somebody who has an exploratory fantasy, they may have been cheated on in the past, or they may have feelings of jealousy in the past. And so engaging in this type of fantasy helps them to regain control over themselves in an erotic way. In the book, The Erotic Mind by Jack Morin, he talked about how we're most excited when we must overcome obstacles, and that anxiety, guilt, and anger actually heighten our sexual arousal. He would also say that unresolved issues of shame actually intensify our passion. So it really raises the question, is this something we want to shame people for further? If maybe they had shame in the past and it contributes to their erotic desire, but do you shame them more for the desire? It really raises the question. So some people point out that sexual desires or erotic interests can sometimes be a repair attempt to reenact and resolve past hurts or traumas. But it's not always the case, but it can be. So do we focus on helping them heal? That's one of the questions that sometimes arises. I like to say that there's a balance. We need to have the right balance between promoting healing and growth versus acceptance and grace. So many times in the past, the counseling professions and the churches put a lot of emphasis on healing and growth. Okay, so because somebody was hurt in the past, therefore you have to resolve that wound. Well, that may be important, but if you just focus on that, it may actually reinforce the shame that people have. It may make people feel bad that they have this erotic interest. On the other hand, if we promote acceptance and grace, it helps people to find happiness and acceptance where they are now, not when they are changed. For example, I once had a girl who came to see me, and she talked about how her boyfriend she wanted her boyfriend to bruise her, but he didn't want to. This is actually not, it wasn't his idea, it was actually her idea. And so, her boyfriend didn't like it because he thought this was really strange and weird and he didn't want to hurt her. But she really wanted it. It helped turn her on. So we try to understand where this came from. And as it turned out, she had actually been abused sexually as a younger girl. And so she had learned to associate abuse with being loved. So now, while I'm not sure if I would want somebody to continue to hurt themselves, I didn't want to make her feel bad for having this attraction when she was a victim of abuse. Instead, I try to help her understand that this had a pretty rational explanation, and maybe she could find a way to accept that part of her and not shame it. Maybe, I don't know if she would want to continue to hurt herself, but maybe there's ways of getting that same kind of experience without necessarily going all the way. But instead of trying to shame her for it, we try to help her find acceptance and work with it. Now, I want to talk about sexual orientation next. This is also an important subject in sexual behavior. Sexual orientation refers to a person's sexual attraction for members of a particular sex. When a person is attracted to the opposite sex, they're considered to be heterosexual. When a person is attracted to the same sex, they are considered homosexual. A person who is asexual has no sexual desire for any partner. Now, for homosexual-oriented people, we have several types of people. There are a lesbian is a woman with a sexual orientation toward other women. A gay male has a sexual orientation toward other men. And a person who is attracted to both men and women is considered to be bisexual. LGBT stands for lesbian, gay, bisexual, and transgender, which covers the range of both sexual and gender identity minorities. And again, sexual orientation can occur on a spectrum. So like we saw with Alfred Kinsey's scale, someone can be exclusively heterosexual, or they can be exclusively homosexual, or they can have a range of degrees of bisexuality. One person may be predominantly heterosexual, but slightly interested in the opposite sex, of the same sex, or vice versa. So sexual orientation is not either or, but rather exists on a continuum. Now, while sexual orientation is fixed and unchanging, sexual fluidity refers to the idea that people do not fit into rigid categories. In fact, they may unconsciously experience slight shifts in their sexual attractions or identity, though there is some debate about the nature of this. Homophobia. Let's talk about some other implications of sexual orientation. Homophobia is a fear and hatred of people who are homosexual. And so that leads to problems with people really embracing their sexuality. LGBT adolescents often have difficulty coping with their sexual orientation in a culture that stigmatizes homosexuality. Many gay or lesbian people oftentimes begin with a mixed orientation relationship. That means they start out with a relationship with someone of the opposite sex before they actually embrace their homosexuality. And this is often due to the need to conform socially, or simply just to have a child because they want to have a child the natural or biological way. For LGBT people, coming out is a process of acknowledging their sexuality and then disclosing the truth to their friends, families, and others. This can be challenging because of the social stigmas involved. Let's talk about the etiology of sexual orientation, or why do people have the sexual orientation that they do? Sexual orientation results from complex causes that probably include both biological and social factors. Anyone who claims a definitive answer is probably wrong. So there are people who try to say that sexual orientation is all biological, and there are some people who say it's a choice. But that's not correct. And it's not true that it's completely biological either. There are a little of both. Twin studies suggest that homosexuality is more common among monozygotic twins or identical twins than dizygotic twins or fraternal twins. That indicates that genetics has some influence. But research has so far failed to identify any specific gay gene. The concordance rate, which is the correlation between twins, is probably around, and it varies depending on the study, but it's around 60%. So it is highly heritable. However, it's not 100%. That means that there are other factors that can play a role. So just because you have one twin who's gay does not necessarily mean that the other twin will be gay, although they have a higher chance of it. Sexual orientation might be influenced during prenatal development by hormones circulating in the mother's body. That's one theory. But here's another point. Gay males actually had a higher rate of child sexual abuse compared to heterosexual males, which is why some may question or hate their same-sex orientation. Many boys are sexually abused and groomed for a homosexual relationship by a male adult, and this is child abuse. I've personally interviewed many clients who have developed a gay orientation because of sexual abuse. Some people will say, well, they were always gay prior to that. Well, I tend to take people at their own self-assessment. If they believe that they're sexual, they believe that their sexuality was affected by it, then I'm going to take them at their word. But there is some controversy about it. It's still unclear whether the sexual orientation existed prior to the abuse or not. It has been argued that some people may be singled out for the abuse because of their pre-existing sexuality. So that's possible too. It's really hard to know. But here's the consensus. The consensus seems to be that sexual abuse may disorient someone sexually, but it's usually not sufficient to orient someone sexually, as sexual orientation is far more enduring than a mere erotic interest and has a biological component as well. So in the case of the people that I've talked to who had a response due to sexual abuse in the past, those people would be typically classified as bisexual. So they're not going to experience a major shift to the other extreme, the other end of the spectrum. So it's important to understand. Someone doesn't become homosexual by choice, and they don't, and they certainly, trauma and past abuse isn't enough to explain a complete shift. For some people who are completely gay, they're going to say, or completely, they would identify as 100%, oriented to the same sex. They may say they never had a trauma in their past or abuse in the past. So that theory doesn't fit them. But for some other people, they may say it was due to abuse. So it's really hard to know. That's why it's important to understand that sexual orientation, the ideology of it, is very complex. There's no easy answers, and it's not sufficient to say it's caused by one thing or another. This has contributed to certain models of therapy that have been designed to change people's sexual orientation. So reparative therapy was a controversial therapy model that tried to change sexual orientation. It was predicated on the idea that sexual desires serve a reparative function in healing unresolved shame and attachment loss. So early on, it caught a lot of notoriety because it seemed like it fit for a lot of people. And so the name of the book was called Shame and Attachment Loss because of that. But it did not intend to mean that people were broken. However, while it did fit some people's experiences, those who suffered abuse, other people have rejected this, saying that, no, I wasn't abused, and many people who've tried to change fail. And so sexual orientation is not generally changeable, and the efforts to try often reinforce stigmas and shame. So it really comes back to that question of, do we try to change people, or do we try to accept them where they're at, even if they did experience abuse? Maybe the sexual orientation or the desire was a result of something, but do you try to change it, or do you try to help people find acceptance? So unfortunately, a lot of times Christians put a lot of emphasis on healing and growth, but at the expense of acceptance and grace. So when we put the emphasis on healing and growth, which it comes from I believe it comes from a well-intentioned place because they care about people who are hurting. But when you're focused on growth and healing, but you're not accepting people where they are, it can actually reinforce shame and make people feel worse when they don't change. So I think personally, as a Christian, I like to put the emphasis on acceptance and grace, acceptance of where people are, not where society thinks they should be. So that's something to think about. Let's talk about sexual health. How do we protect ourselves sexually? Well, first of all, we have to be careful about sexually transmitted infections, or STIs. Sexually transmitted infections, or STIs, are any disease that is spread through sexual contact and can affect the sexual organs and the ability to reproduce. It may result in pain, disfigurement, and even death. These include chlamydia, syphilis, gonorrhea, genital herpes, genital warts, and AIDS, or HIV. In the United States, about 20% of sexually active teenagers have an STI. That's 1 in 5 sexually active teenagers have an STI. Rates of all these STIs are especially high in emergent adulthood. Those are college-age young adults, basically. Among adolescents, the most common STIs are genital herpes and chlamydia, although rates of HIV infection are rising. For those who live near our university, I want my students to know this, that health officials in Montgomery County, Maryland in 2018 called the upward trend in chlamydia, gonorrhea, and syphilis cases a public health crisis after levels of infection have reached the highest in a decade and are especially high among adolescents and emerging adults. Officials want to make condoms freely available to high school students. Now, this may be controversial to people because they don't want people to have sex, but the reality is if they're having sex, we need to help them protect themselves because there are a lot of sexually transmitted infections going on. For those who live near us in Washington, D.C., in 2018, there were a record number of new cases of gonorrhea. 1/3 were adolescents and emerging adults. Chlamydia was also high, and syphilis. Chlamydia, half of them were adolescents and emerging adults. That's pretty sad when you think about how many people are catching STIs. Now, there's 2 types of STIs. There are viral infections and bacterial infections. Viral infections include genital herpes and HIV. The problem with that is that there are no cures for these types of infections. Treatments are available for HPV, but none attack the underlying virus, so it recurs often. And for bacterial infections, it can usually be treated effectively with antibiotics, as in the case of chlamydia. Now, many persons with a sexually transmitted infection may be asymptomatic, meaning they show no symptoms of the disease, but may potentially affect others. The latency period is a period between the time a person is infected with the disease and the time the symptoms appear. So if that latency period is long, you might think, oh, you don't have the STI, but you could be a carrier of it. You may not have symptoms, but you may give that STI to somebody else who may get the symptoms before you do. I've had people who were carriers and they gave a virus to somebody else who then died before they did. So that's possible. Let's talk about HIV and AIDS. A sexually transmitted viral disorder that causes deterioration of the immune system and eventually results in death due to complicating infections that the body can no longer fight is known as acquired immune deficiency syndrome, or AIDS, AIDS. AIDS is caused by the human immunodeficiency virus, or HIV, which wears down the body's immune system, making the individual highly susceptible to infections. HIV can be transmitted from person to person through exposure to bodily fluids, including blood, vaginal fluid, semen, and breast milk. There are no documented cases of the spread of AIDS through tears or saliva, so it's something to be aware of. The virus typically enters the body through the rectum, vagina, or penis during anal sex or vaginal intercourse. Another common form of transmission is through shared needles among intravenous drug users, so that's also a common way people catch HIV or AIDS. After the HIV virus is acquired, During the HIV latency period, a person may experience flu-like symptoms, including fever, sore throat, fatigue, and swollen lymph nodes in the neck and armpits. After this initial outbreak of symptoms, no further evidence of the disease may appear until years later. So as I said, somebody may be a carrier of the HIV virus and give it to somebody else while they may be asymptomatic. So how do you protect yourself? Contraceptions such as condoms, IUDs, and birth control pills are highly effective in preventing unplanned pregnancy. That's why they're called birth control, but they do not prevent STIs. Condoms can reduce STI risk during sexual activity, but they are not 100% effective. Condoms might reduce HIV transmission by 85 to 95%. However, slippage, breakage, and incorrect use may reduce the overall effectiveness of condoms to as low as 60 to 70%. So technically, abstinence is the most effective prevention against HIV. However, many young people will engage in sex anyway, so it's important to be prepared. A condom is better than nothing and prevents unplanned pregnancies too, so that's also a benefit as well. While it may not prevent STIs 100%, it at least prevents unplanned pregnancies, which is also important to people's lives as well. What they have found is that abstinence-only education isn't effective in preventing HIV. In fact, sometimes when people put too much emphasis on abstinence, it actually can open up people to be more at risk for STIs because they're not adequately prepared. So it's important to be prepared. There's a campaign called The Power to Decide, and this is the campaign to prevent unplanned pregnancies. They seek to improve the lives and future prospects of children and families by helping to ensure that children are born into families who are committed to and ready for the demanding task of raising the next generation. So their goal is to ensure that all young people, no matter who they are, where they live, or what their economic status might be, have the power to decide if, when, and under what circumstances to get pregnant and have a child. While protecting ourselves from STIs is important, it's also important to remember that unplanned pregnancies can derail people. It can derail their career prospects or their educational prospects if they have to take a detour to raise a child that they were not planning for. So it's important to help young people to know that they can plan for their pregnancy and to be able to control when they have a child. Unfortunately, in our society, it's still taboo to talk about the use of contraceptions because it seems like we're encouraging liberal sexuality. People are going to engage in sex whether we like it or not. Without contraception, people are going to get pregnant. And so it's important for people to be prepared so that they know they don't have to have a baby prematurely before they're ready. So it's important to help people know how to use condoms, to teach them that they can assert themselves and ask for a condom to be used. But there are also times when people, even as much as you may use condoms or assert your needs, or maybe times when a partner is not respectful of that. And so we also want to stand up for people who are, victims of rape, for example, and to help people who are in those kinds of situations. Not all unplanned pregnancies are because people forgot to have a condom either. So that's why. That also brings us to the subject of sexual consent. As we talked about the role of power and the use of condoms, it's also important to know that people have the right to say no. Unfortunately, in our society and in the world around us, there's oftentimes a rape culture. Rape culture describes an environment in which rape is pervasive and normalized due to the social attitudes about gender and sexuality. For example, this idea that boys will be boys, and that boys can be aggressive, and that will overlook rape. Unfortunately, rape culture tends to put the blame on victims, particularly women, for somehow being responsible for not being raped. For example, if someone's raped, People oftentimes wonder, well, what did she do to invite it, or what was she wearing? Rather than looking at what did the man do, or put the responsibility on the man to not rape. So more emphasis needs to be placed on teaching people about the importance of consent and respecting each other's right to say no or their boundaries. Yes means yes and no means no, unless you're in a fantasy role play, for example, where you've negotiated in advance. But even then, you still have there's still consent, and there's the use of safe words. So it's important for people to understand that yes means yes and no means no. We are winding down our Higher Change series, but I hope you can join us for our future chapter called Appreciating Beauty, about the need for grace. Thank you for being a part of this series.